Welcome back to the Deep Dive, where we tear through the latest sources, research papers, and clinical notes so you can walk away instantly well-informed.
That's the goal.
Today, we are undertaking a really critical mission to extract the essential knowledge around a chronic skin condition that is, it's so frequently misunderstood.
And misdiagnosed.
Absolutely. It causes real distress for the millions who deal with it. Papulopustular Rosacea, or PPR.
That's right. So for anyone needing a complete roadmap of this type 2 rosacea,
Yeah.
from, the surprising biological factors to how experts classify it and the huge range of treatments, this deep dive is for you.
We want those aha moments.
Exactly. We're aiming for the insights that separate just knowing about it from truly understanding it.
Okay, so we have to jump immediately to the big confusion point because this is where I think most people get tripped up.
Mm-hmm.
PPR is constantly mistaken for common acne. And that mistaken identity, it leads to months, maybe even years, of using the wrong products.
And chasing the wrong solutions. It's a frustrating cycle.
So, what is the single non-negotiable diagnostic landmark that tells us we are absolutely dealing with PPR and not acne?
Well, the landmark is actually defined by an absence, not a presence. The giveaway is what PPR lacks. Comedones.
And Pudnones meaning?
No blackheads. And no whiteheads.
Wait, okay, hold on. If you have bumps and lesions filled with pus, why wouldn't you have blackheads? Isn't that just a natural progression of a clogged pore?
And that's the critical distinction. It's a great question. Acne vulgaris is a disease of the pilosebaceous unit where pores get clogged, keratin builds up, and that leads to those comedones.
Right, the plugs.
Exactly. PPR, on the other hand, is a purely inflammatory condition. The lesions, the papules and pustules, they're the result of a hyperreactive immune system response under the skin.
So the pore itself isn't blocked?
The pore structure isn't blocked by plugs of oil and dead skin, no. The inflammation is just pushing up through the surface.
Wow. So the insight here for you, for the listener, is huge. If you're struggling with redness and bumps on the center of your face and you're trying benzoyl peroxide or salicylic acid,
Treatment's designed to break up comedones.
you're treating the wrong disease, which is not only ineffective, but is probably just irritating your skin even more.
Exactly. It's often a total waste of time and money because the underlying problem needs anti-inflammatory targeting, not pore clearing.
Okay, so let's unpack this official classification. If we define PPR by what it doesn't have, what are the symptoms that define its presence?
The core of papulopustular rosacea, or type 2, is what we call persistent central facial erythema.
That's the redness that just won't go away.
It never goes away, and it's combined with those specific red, swollen papules and the pus-filled pustules. They typically cover the most prominent parts of the face.
So the cheeks, chin, forehead, and nose.
That's right.
And what does that mean? What does it feel like? It sounds really intense.
Oh, it is. It's incredibly intense. Visually, the skin looks inflamed, hot, sensitive.
Right.
But patients frequently report this subjective sensation that the skin is actually warm or even hot to the touch.
Mm.
And that's often accompanied by burning or stinging.
And flushing, too, right?
And regular flushing episodes where the redness just dramatically spikes.
You mentioned this classification comes from the National Rosacea Society Expert Committee. Why is type 2 such a necessary label? Why not just call it rosacea with bumps?
Because the classification type 2, it's essential. It standardizes the diagnosis across the globe, and crucially, it dictates the treatment path.
It's a roadmap.
It's a medical roadmap. When a provider diagnoses type 2, it immediately points toward an anti-inflammatory approach. That might mean topicals like metronidazole, or maybe oral meds like doxycycline.
Okay, so this is where it gets really interesting, connecting the dots between the types. The presence of these papules and pustules defines type 2. What happens if someone has all that redness but none of the bumps?
That moves us squarely into type 1, erythematolangioectatic rosacea, or ETR.
ETR.
But the sources confirm ETR is all about that chronic redness, visible blood vessels, we call them telangiectasia, and frequent flushing. But critically, it lacks those inflammatory lesions.
So type 1 is more of a vascular issue.
Right, while type 2 is inflammatory.
And what about the less common types?
Then you have type 3, phymatous rosacea, which thankfully is much rarer. This involves irreversible skin thickening and enlargement.
That's the one you sometimes see on the nose, rhinophyma.
Exactly. PPR has the inflamed bumps, but not this deep structural texture change. And finally, type 4 is ocular rosacea, which affects the eyes, causing discomfort and irritation.
Okay, so we've classified the symptoms, but symptoms are just the reaction. Let's dig beneath the surface. You said earlier the exact cause is unknown, but the sources point to a cascade of internal drivers.
What's fascinating is how multifactorial it is. It really suggests that the treatment has to be multi-pronged too. We know genetics play a role. If you have a family history, you're predisposed.
But that's not the whole story.
Not at all. The functional heart of type 2 is immune system dysfunction. An abnormal, overactive, innate immune response leads directly to that chronic inflammation and the formation of the pustules.
It sounds like a biological overreaction to something that shouldn't really cause a problem. Which brings us back to the infamous microscopic residents of our skin.
Ah, yes. The Demodex mites.
Tell us more about that connection.
So Demodex folliculorum are tiny mites that live on all of us in our hair follicles. It's normal. But in PPR patients, they're found in way higher concentrations.
How much higher?
Sometimes 10 to 20 times higher. But here's the crucial deep dive insight. It might not be the mites themselves that are causing the bulk of the reaction.
What are they doing then? If they're on everyone, how can we be sure they're not just a byproduct of the condition instead of the cause?
That's a fantastic question one researchers pursued for years. We now believe that when the mites die, they release a specific bacterium, Bacillus oleronius, and their own waste products into the skin.
So it's their debris.
It's their debris. It's believed that the decomposing mites, or what they leave behind, is what triggers that hyperreactive immune response we just talked about.
And that leads to the massive inflammatory cascade.
The redness, the papules, it's an inflammatory response to their decomposition.
Wow. So you have a genetic predisposition, a dysfunctional immune system reacting to microscopic biological debris, and then the vascular issue on top of that.
Exactly. Vascular abnormalities mean the blood vessels in the central face are leaky or just constantly dilated. And that increased blood flow is what gives you that persistent background redness. It's a really complex, multi-layered problem.
Okay, that's the internal picture. But for the listener, daily life often comes down to managing the external and lifestyle triggers.
The flare factors.
Right. Dealing with PPR means being hyper aware of what sets it off.
And these are vital because they're the elements we actually have some control over. Environmental triggers are massive. Sun exposure is probably the biggest one.
Along with wind and extreme temperatures.
Both hot and cold, they just stress the capillaries.
And everyone immediately thinks of diet. Spicy food, alcohol, hot drinks. Why are they such notorious culprits?
Because they're strong vasodilators.
Meaning they widen the blood vessels.
They rapidly widen them. When blood rushes to those already compromised capillaries in the rosacea-prone skin, it just intensifies everything. The redness, the flushing, the irritation.
And the sources also link it to things like chocolate, dairy, caffeine.
Yes, for certain individuals, those can increase inflammation.
That is basically a list of everything enjoyable in life. It really highlights how strict trigger avoidance has to be. And stress. How does stress physically make PPR worse?
Stress is a master conductor for inflammation. Emotional stress causes the body to release high levels of hormones like cortisol.
Right.
And cortisol influences the inflammatory pathways and, crucially, increases blood flow to the face. So that combination promotes irritation, swelling, and increases the frequency of pustules.
We also need to touch on hormonal changes, which are often overlooked.
Definitely. Hormonal fluctuations, like in pregnancy or the decline in estrogen during menopause, can significantly contribute to the onset or worsening of PPR.
Why estrogen?
Estrogen plays a protective role in maintaining the skin barrier. When those levels drop, the skin gets thinner, more susceptible to moisture loss, and much more reactive to all those other triggers.
Okay, let's turn to skincare ingredients, because this is where a lot of self-sabotage happens. The sources are extremely clear about certain cosmetic ingredients being absolute enemies for PPR skin.
This is a crucial section for you to hear. We have to warn against volatile alcohols, specifically alcohol denatured.
Okay.
Think of your skin barrier like the protective clear coat on a car. Alcohol denatured is an intense solvent that physically strips away the protective lipids. It dissolves the glue holding your skin barrier together.
Wow, that is a powerful metaphor. What does that chemical stripping do to the already inflamed skin?
It leads to two main problems. First, it increases water loss, leaving the skin dry and vulnerable. Second, it evaporates so rapidly that it stresses the nerve endings in the skin.
Which causes?
It drastically intensifies the characteristic burning, the redness, and the pustule formation. It actively hurts already sensitized skin.
And what about benzyl alcohol? I see that used as a preservative a lot.
Benzyl alcohol is a known irritant for sensitive skin. When you put it on an already compromised PPR barrier, it frequently leads to immediate intense stinging, burning, itching, and it contributes directly to that inflammatory cascade that results in new pustules.
So if you have PPR, you have to be an ingredient detective.
Rigorously. Check your ingredient list for both of those because they are major flare accelerators.
So given this whole complex internal picture and all these external triggers, what does effective management actually look like?
Well, the goal is to reduce inflammation and support the skin barrier. So you need a multi-layered approach.
Right, it's two tracks.
Precisely. We focus on the medical heavy hitters to get the inflammation under control, and then the daily strategy to keep the barrier intact and avoid future flares.
Let's start with the medical firepower for those moderate to severe cases.
The primary goal is controlling that underlying inflammation. So the first line of attack is often topical. Metronidazole, azelaic acid, or ivermectin cream.
And those are all anti-inflammatory.
They all have proven anti-inflammatory properties to calm the skin and reduce pustules. For more significant cases, oral antibiotics like tetracyclines or doxycycline come into play.
And this brings us back to that crucial insight. We're not necessarily using these as standard antibiotics, are we?
No, and this is a key piece of information. Doxycycline is often prescribed at a sub-antimicrobial dose.
Meaning it's too low to kill bacteria.
The dosage is too low to act as a conventional bacterial killer, but it's precisely the right dose to target and block the inflammatory pathways active in rosacea. It's functioning purely as an aggressive anti-inflammatory.
Which is much safer for long-term use.
Much safer.
Okay, what if things are resistant to that?
For resisting cases, a doctor might consider oral isotretinoin. And because type 2 often coexists with vascular problems, laser or IPL treatments can be used to shrink those dilated blood vessels and reduce the background redness.
But that won't treat the papules.
No, just the redness. And for temporary relief from really intense flushing, there's brimonidine gel, which locally constricts blood vessels.
Okay, so that's the medical side. Moving to the daily strategy. The foundation is the skincare routine. You can't put powerful meds on a barrier that's already screaming for help.
Absolutely not. The daily routine has to be hyper-gentle. Mild, non-foaming cleansers and heavy, non-irritating moisturizers are non-negotiable.
The priority is barrier repair.
It's everything. And this is why the sources specifically point to gentle eczema moisturizers.
That seems a little counterintuitive. Why use eczema products for pustules?
Because the underlying problem is similar: a compromised skin barrier and high inflammation. Eczema moisturizers are packed with ingredients like ceramides and fatty acids.
The natural building blocks of the skin barrier?
Exactly. By applying them, you are physically reinforcing that lipid layer, which reduces water loss and makes the skin less vulnerable to every single trigger.
So it's structural repair. Now, are there safe alcohols to look for as opposed to the ones we warned against?
Yes, you should look for fatty alcohols like cetylate or stearyl alcohol. Unlike the volatile ones, these are long-chain molecules that function as emollients.
So they soften the skin.
They soften it and help prevent moisture loss. They actively support the barrier. Completely safe for PPR skin.
I also see mention of some more specialized modern treatments designed for immediate calming.
Yes. Hypochlorous acid spray is gaining a lot of traction. It's a mild compound that has both anti-inflammatory and powerful antibacterial properties.
So it's like a toner replacement.
An excellent toner replacement. It helps calm the skin by eliminating surface bacteria and debris without causing any irritation. And, of course, the most non-negotiable daily step for type 2.
Sunscreen.
A broad-spectrum sunscreen with high SPF applied religiously.
So we've covered the medical firepower, but what about the smaller daily fixes and supplemental remedies that the sources pointed to?
These are generally for soothing and minor inflammation relief. You see ingredients like aloe vera for cooling and raw honey, which has natural antibacterial effect.
Turmeric.
Turmeric, specifically the compound curcumin, is noted for its powerful anti-inflammatory actions, used internally or topically.
What about things from the pantry?
Green tea has potent antioxidants. Oatmeal is excellent for relieving itching. And niacinamide, a form of vitamin B3, is consistently shown to improve barrier function and reduce redness.
So summarizing everything we've covered, effective management for you, the listener, is about combining systemic discipline with targeted therapy.
That's it. It means recognizing that PPR is a distinct inflammatory disease type 2, rosacea, fueled by an overactive immune system and factors like Demodex debris.
And management is a two-track necessity.
Absolutely.
Huh.
You have to implement a targeted medical routine to reduce the lesions and inflammation and maintain rigorous trigger avoidance and a consistently gentle barrier-supporting skincare regimen.
With ingredients like ceramides and high SPF, while avoiding those stripping volatile alcohols.
That's the formula.
Okay, so if we connect this to the bigger picture, we've established that papulopustular rosacea is driven by these complex inflammatory factors right on the central face.
Right. It's a chronic condition demanding very specific anti-inflammatory care.
But even though PPR has its own distinct identity, the source material notes that these chronic inflammatory facial conditions rarely exist in a vacuum.
They often overlap.
So here is a final provocative thought for you to explore. The challenging, often overlooked connection between papulopustular rosacea and seborrheic dermatitis.
That overlap is a nightmare for diagnosis. Seborrheic dermatitis presents with flaky, greasy, sometimes yellowish patches, often in the T-zone.
Around the nose, eyebrows, scalp.
Right. But they share underlying mechanisms.
How so?
Both are associated with an overactive immune response. And crucially, both are implicated by the presence of a yeast, Rosacea.
Ah.
So when these two conditions overlap on the central face, they can mimic each other so closely that they become notoriously difficult to distinguish.
And trying to treat one aggressively might just make the other one worse.
Exactly. It makes management exponentially harder.
So understanding that potential overlap, the dual role of inflammation and Rosacea in the same location, that is the next level of well-informed knowledge in treating chronic facial inflammation.
It's definitely something worth discussing with your healthcare provider if you suspect overlapping symptoms. An excellent starting point for further exploration.
That's it for this deep dive. Thank you for tuning in.